So with infectious illnesses, there are some things like some clues that you may get from dispatch or your scene size up, your assessment or history that may give you a heads up that there's some kind of infectious disease going on here. So those things might be like a fever. Fever is one of the, very often an indication of infection, but there are other causes that can cause increased body temperature, like environmental stuff. And not all infections result in a fever. So it's not the end-all be-all, but it's a good tool. Some other things, some other signs and symptoms that you may see or come across. Coughing, vomiting, diarrhea, ultramental status, all can be from infections or other causes. So this is where a good assessment and history and size up really come into play. We want to look at our findings with patterns that are associated with certain infectious diseases, and make sure that you follow up sometimes on these patients to see if what you were suspecting is correct. Now, with your infectious illnesses, the risk of exposure may not always be so obvious as other hazards. Like you see a power line down, oh, that's a power line, I'm not going to mess with it. But you may not always see tuberculosis, or you won't see meningitis, like they don't have neon signs flashing over their head saying that this is what I have. Because these indications are a little bit less obvious, it's really important to anticipate situations where there might be a little bit higher risk for you or patients for exposure to infectious illnesses. As with all hazards, your whole goal is to protect yourself, go home safe, protect your family, your team members, and your patients from harm. So you've got to evaluate your risk to exposure. You've got to evaluate your patient's vulnerability to infection. All right, some dispatch information can help you anticipate, the possibility of a patient who's at risk for infectious illness. Some population characteristics and living arrangements of some residential facilities can kind of create a higher risk factor for transmission of some of these illnesses. Age also plays a part of it, general health status, or behavioral risk factors like IV drug abuse. So when you respond to group homes or nursing homes, homeless shelters, correctional facilities, things like this where people live and interact with each other in a fairly confined space, just be aware that there's a possibility that that patient or other people there may have, some infectious diseases. They're at a higher risk already. And there are a bunch of different chief complaints that can be associated with other problems, but also with infectious disease. This is your fever, your cough, your nausea and vomiting and diarrhea, muscle aches, headache, pain, stiff neck, things like that. Now, there are some additional specific signs and symptoms of certain illnesses. For respiratory illness, nasal congestion, burning eyes, irritation, rhinorrhea, which is just a nasal discharge, earache, sore throat, cough productive or non, wheezing, rales, crackles, any kind of distress, stridor, drooling, hoarseness, all these types of things. For hepatitis, upper right quadrant tenderness, jaundice, dark urine, clay-colored stools, anorexia, those all fit with hepatitis, acute and chronic. Meningitis has stiff neck and photophobia, and maybe purpura. So it's really important to just have a good understanding of the different diseases and the more common presentations so that you can be prepared for it and utilize the appropriate PPE that is for your situation. So primary assessment, of course, you check your pulse, right? If they are unresponsive and not breathing, start CPR. Right? Some infectious diseases like epiglottitis and croup can cause an upper airway obstruction, so make sure that you listen for stridor, look for tripoding, look for any drooling. If you suspect any kind of airway edema, then do not examine that airway or put anything in their mouth because a complete airway obstruction could occur. Otherwise, use your basic manual maneuvers and basic adjuncts to establish your airway. If they are unresponsive, consider the need for an advanced airway. And give them oxygen if they're hypoxic and assist ventilations as needed. If they show signs of shock, consider the need for fluid replacement. For your secondary assessment, for a critical patient, you're going to do a rapid medical assessment. You're going to listen to breath sounds. For your non-critical, you're going to perform a focused physical exam based on their chief complaint and presentation. And we're going to use the sample and OPQRST to kind of figure out what's going on or what's likely to be going on, what their problem is. So you've got to understand the patho behind these illnesses and take the patient's responses to develop your line of questioning and kind of adapt your assessment as you get more information from the patient. If they say that they don't have a cough, ask them about other signs and symptoms. If they say they have a cough, Then follow up with what type of cough is it, the nature of that cough, is it productive, non-productive, dry, hoarse, things like that. We're not always going to get just a definitive diagnosis for most of these infections in the pre-hospital setting, but we can figure out what is most likely, and this may change some of our treatment, our PPE options, and our transport options to where we take the patient. Test your hypotheses and figure out whether or not there's an infectious disease that fits some of the criteria here. Now, treatment's going to be based on their complaints and problems rather than just a specific diagnosis. In addition to any interventions in the primary assessment, consider your findings from your secondary to develop a plan. Do they need bronchodilators? Do they need IV fluid? Do they need assistance with temperature regulation? They may have an underlying illness like COPD or asthma. You may want to consider a beta-2 agonist for this if your protocols allow. They may be, patients with a fever or infection or tachypnea may have some dehydration or may be prone to dehydration, so they may benefit from some IV fluids. If they have a fever. Now, typically a low or moderate fever is not treated pre-hospital, but treatment with acetaminophen or ibuprofen may be in some services protocols, especially if they have a longer transport time. Patients with sepsis may be hypothermic, so we don't want to have any more heat loss. If they're hyperthermic, we don't want to keep them bundled up in there. Important note as far as temperature regulation. We never, ever, ever give aspirin to pediatric patients who have a fever. It's rare, but there is an association between aspirin and Reye's syndrome, which can cause some pretty significant problems in your pediatric patients. So we never, ever, ever give aspirin for this, for fever in a pediatric patient.